Welcome to the deep dive. So you've sent us your MSRA revision notes on primary biliary cholangitis, or PBC, and that's exactly what we're going to unpack for you today.
That's right.
Our aim, really just to boil those notes down to the essential info you need, make this a sometimes tricky topic clear, concise, and hopefully memorable for the exam.
Precisely. You've done the groundwork, gathering the material. We're here to sort of guide you through it, pulling out those really high yield points from your notes on
Yeah.
BBC. Think of it as a walkthrough, covering everything from, the definition right through to management, prognosis, complications,
Yeah.
the key takeaways.
Okay, great. Let's get right into it then. What exactly is primary biliary cholangitis?
Okay, so fundamentally, PBC is an autoimmune disease. It targets the small bile ducts, the tiny ones inside your liver.
Right.
These are the channels that carry bile away. Now, the name is important. It used to be called primary biliary cirrhosis.
I remember.
Yeah, but cirrhosis now really refers to the late stage, when there's significant scarring. So PBC itself is the earlier ongoing autoimmune attack on those ducts.
So it's a process, not just an endpoint.
Exactly.
Yeah.
It's chronic, it's progressive. It's this misdirected immune attack on the bile ducts within the liver lobules, the intralobular bile ducts. This causes inflammation, and over time, well, that leads to fibrosis, scarring.
And that can eventually lead to cirrhosis?
It can, yes.
Yeah.
Over years, potentially decades, it can progress to cirrhosis and cause real problems with liver function.
Okay, so the immune system is the culprit here, but what actually sets it off? What's the etiology?
That's the million-dollar question, really. We don't have a single smoking gun, but it seems to be a mix of factors. There's almost certainly a genetic predisposition. Some people just genetically more likely to get it. And then we think some kind of environmental trigger likely kicks off the autoimmune process in those susceptible individuals.
Yeah.
Key pointers are the presence of those specific antibodies. The antimitochondrial antibodies, AMA, will definitely come back to those.
Right.
And also the specific pattern of damage you see in the bile ducts if you look at a biopsy.
So genes load the gun, environment pulls the trigger kind of thing.
That's a good way to think about it, yeah. The evidence for genetics comes from things like higher concordance rates in identical twins compared to non-identical twins. And also a family history of PBC or even other autoimmune conditions seems to bump up the risk.
Interesting. That interplay, is there a simple way to maybe remember that sequence?
Well, you could try thinking, get a PBC, so G for genes, E for environment, T for trigger, A for autoimmune attack, then PBC for the target bile ducts and the potential outcome, cirrhosis.
Get TAPBC. Genes, environment, trigger, autoimmune, bile ducts, cirrhosis. Okay, I like that. It helps sequence it. Now, who is most likely to get PBC? What are those key risk factors we should know?
Okay, the big ones are female gender. It's much more common in women. Middle age, typically diagnosed between, say, 40 and 60. And having a family history, either of PBC itself or other autoimmune diseases.
And the genetics we mentioned play in here too.
Yes, absolutely. Certain specific genetic variations are thought to increase a person's susceptibility.
Right. So predominantly middle-aged women, maybe with a family link. Got it. Let's drill down a bit into the pathophysiology, what's happening inside the liver.
Okay, so the core issue, the pathophysiology, is this misguided immune response. Your immune system mistakenly sees the cells lining those small bile ducts as, well, foreign invaders.
And attacks them.
Exactly. This triggers inflammation right in those tiny ducts. Because it's chronic, this inflammation causes progressive damage. Bile flow gets sluggish, backs up a bit, the liver tries to repair itself, but this repair process leads to fibrosis scarring. And if it keeps going, that scar tissue messes up the liver's normal structure and function.
So like you said before, the plumbing gets clogged by the immune system's attack, causing a backup and damage.
That's a really good analogy. Those tiny ducts get inflamed, narrowed, blocked, bile can't get out properly, builds up, and that damages the liver cells around them.
Makes sense. Okay, so someone comes in, maybe jaundice, maybe itching.
Mhm.
What else could be causing similar symptoms? What are the main differential diagnoses?
Yeah, that's crucial. When you see cholestasis that reduce bile flow, you need to think broader. Key things to consider are autoimmune hepatitis. That's another autoimmune liver disease, but it targets the liver cells, the hepatocytes, more directly.
Right, different target.
Then there's primary sclerosing cholangitis, PSC. That also affects bile ducts, but usually the larger ones, both inside and outside the liver. It's a different beast.
Okay.
You also have to rule out things like viral hepatitis, maybe a drug reaction. Thiazines are a classic example, and even sarcoidosis, which can sometimes involve the liver.
So getting the diagnosis right is key because the treatments will differ.
Absolutely critical. You need to know what you're treating.
Makes sense. What about the bigger picture? Who gets PBC? The epidemiology.
Okay, so in the UK, prevalence is estimated around 40 to 65 cases per 100,000 people.
Wow, okay.
But the really striking thing is the female-to-male ratio. It's about 9 to 1. Hugely predominant in women.
9 to 1. That's significant.
It really is. Median age of diagnosis is around 65, and it's pretty rare under the age of 15. Also seems less common in people of African origin. The incidence, new cases per year, is about 2 to 3 per 100,000.
And that's similar elsewhere.
Yes, similar figures in other Northern European populations.
Yeah.
We did see a rise in prevalence from the 80s onwards, probably better diagnosis and awareness. But it seems to have leveled off more recently, maybe reflecting better survival with treatments too.
That 9.1 ratio is definitely a key fact to remember. Okay, so someone has PBC. What might they actually experience? What are the clinical features?
It can present in different ways, especially early on. But common things are fatigue, and this can be really profound, very debilitating fatigue.
More than just tired.
Oh yes, and pruritus, that's the itching. Often a very early symptom can be incredibly intense and bothersome, sometimes before anything else shows up.
Okay, fatigue and itching are big early ones.
Definitely. Then as things progress, you might see jaundice, the yellowing skin and eyes, hepatomegaly, and enlarged liver you might feel on examination. And sometimes anthelasma, those little yellow cholesterol deposits, often around the eyelids.
Ah, yes, I've seen pictures of those.
Quite characteristic. In the early stages, though, remember, many patients are asymptomatic or just have the fatigue and itching. Jaundice comes later as the cholestasis worsens. Some might get hyperpigmentation too, a sort of darkening of the skin, especially over pressure areas.
Don't need pain.
Less common, but maybe 10% report some right upper quadrant discomfort. And of course, late stage, you worry about progression to liver failure.
Are there other conditions often seen alongside PBC?
Yes, association with other autoimmune conditions is common. Sjogren syndrome causing dry eyes, dry mouth is particularly frequent.
Right. And on examination.
You might find the hepatomegaly we mentioned, maybe the hyperpigmentation, jaundice if it's present, the xanthelasma. And if the disease is advanced, signs of cirrhosis like ascites fluid in the belly or spider naivety on the skin.
That's quite a list. Is there a mnemonic or something for the key features?
How about F, J, H, I, P, J, A? Okay, break that down.
F for fatigue, J for jaundice, H for hepatomegaly, I for itching, P for pain, RUQ, then the second J for jaundice again as its key, A for ascites, late sign, and X for xanthelasma. Covers quite a few bases.
F, J, H, I, P, J, A, X. Okay, I'll try and remember that. So we suspect PBC based on these features. What investigations do we do?
Right. Mainstays are blood tests and sometimes a liver biopsy. The absolute key blood test is for antimitochondrial antibodies, AMA, specifically the M2 subtype.
That's the big one.
That's the big one, found in about 98% of patients. Highly sensitive, although remember, a small fraction, maybe 2%, can be AMA negative.
Okay. What else in the bloods? You might find other autoantibodies, like smooth muscle antibodies, in maybe 30%. And typically, serum immunoglobulin M, IgM levels are elevated.
IgM up. Got it.
And of course, you'll do liver function tests, LFTs. You're looking for that cholestatic picture. Raised ALP, alkaline phosphatase, and GGT, gamma-glutamyl transferase. Bilirubin might be up too, especially later on.
And imaging.
Yes. Crucial to rule out other causes of bile duct problems. So a right upper quadrant ultrasound is standard. Maybe an MRCP, that's the MRI scan, focused on the bile ducts to exclude any blockage in the larger ducts outside the liver, like stones or PSC features.
So bloods for AMA and LFTs, imaging to rule out obstructions.
Exactly. And those serologic tests confirm the AMA titer, usually looking for 1 in 40, and check the immunoglobulin levels, looking for that IgM predominance over IgG. It all helps differentiate from autoimmune hepatitis or PSC. Sometimes, if there's diagnostic uncertainty, especially if you suspect overlap with autoimmune hepatitis, a liver biopsy is needed.
What about staging from biopsy? Is that still common?
Historically, yes. Biopsies were used to stage based on fibrosis portal, periportal, septal, cirrhotic stages. But now, the focus for assessing progression is often more on the response to treatment, specifically UDCA, and monitoring biochemical markers over time using response indices.
Okay, so AMA positivity is really the diagnostic cornerstone. Understood. How do we actually manage PBC?
Right, management. First key point. The only definitive cure is a liver transplant.
Okay, important caveat.
Yes. But medical management is vital for slowing disease progression and controlling symptoms. The first-line drug therapy is ursodeoxycholic acid, UDCA.
UDCA, what does that do?
It's a naturally occurring bile acid. It helps improve bile flow, seems to protect liver cells, and importantly, it's been shown to slow down the histological progression, improve biochemistry and symptoms for many. There's some debate on mortality benefit, but it definitely improves outcomes.
So everyone with PBC gets UDCA.
Generally, yes, it's the standard first-line treatment. Then you need to manage the symptoms, especially that pruritus.
Yes, the itching.
Yeah.
You tackle that.
It can be tough. Early on, maybe simple things like emollients, sometimes sedating antihistamines at night. If that doesn't work, the next step is usually bile acid sequestrants, things like cholestyramine or cholestyramine. They bind bile acids in the gut.
Okay.
For really refractory, difficult itching, rifampicin might be considered, but you need to monitor liver function carefully with that.
And what about nutrition?
Very important. Because bile flow is impaired, you can get malabsorption of fat-soluble vitamins. So patients often need supplements, vitamins A, D, E, and K.
Right. And when would you consider a liver transplant?
Indications usually include advanced liver disease, so things like a persistently high bilirubin, say over 100 micromoles per liter, or a high Melody score, that liver disease severity score may be over 15, or sometimes intractable, life-ruining pruritus that just doesn't respond to anything else.
Can PBC come back after a transplant?
It can, yes.
Huh.
Recurrence happens in maybe 20% or so, usually a few years post-transplant, but it's often not as severe as the original disease.
Okay. So UDCA first line, manage the itch, supplement vitamins, transplant for advanced disease or severe symptoms.
That's the core strategy.
Yep.
And don't forget, managing the potential complications of cirrhosis. If it develops ascites, varices, encephalopathy, all those things need careful attention.
Right. Anything else on management?
Just a few points. Fatigue is really hard to treat. Modafinil is sometimes tried, maybe rituximab in specific cases. If there's an overlap syndrome with autoimmune hepatitis, you might need steroids and azathioprine. Avoid estrogens if possible, as they can worsen cholestasis. Good news is UDCA is safe in pregnancy.
Useful to know. And prognosis prediction.
Yeah, things like prothrombin time, bilirubin, albumin levels help predict prognosis and need for transplants. Scoring systems like the Mayo Risk Score are used too.
Okay, that's comprehensive. What about the overall long-term outlook, the prognosis?
It's definitely improved with early UDCA use. That's made a big difference.
But not everyone responds to UDCA.
No, unfortunately. Up to maybe 40% are considered non-responders or partial responders, meaning their LFTs don't normalize or improve significantly. Their prognosis is poorer.
And without treatment.
If left untreated, the median time from diagnosis to developing abnormal LFTs is maybe 6 years. Survival without transplant really depends on severity markers. For instance, low albumin might mean 3 to 6 years survival, while very high bilirubin could be less than 2 years. Those markers are serious.
So transplant outcomes are generally good.
Generally favorable, yes. Especially for the itching, that often resolves dramatically. Fatigue, less so. Bone disease can sometimes worsen initially post-transplant.
And recurrence is managed.
Using UDCA post-transplant seems to reduce recurrence risk. The role of other immunosuppressants specifically for preventing PBC recurrence is less clear.
Okay. And maybe just quickly, how does it compare to PSC again?
Both involve bile duct damage, sclerosis. But PBC is small ducts, autoimmune, AMA positive. PSC is often larger ducts, intra and extrahepatic, cause less clear, linked often to IBD, AMA negative, different conditions, though both can lead to transplants.
Got it. So the key message for prognosis is really early diagnosis and UDCA.
Absolutely. That's made the biggest impact.
Finally then, what are the potential complications of PBC that we need to be aware of?
Okay, several things. Renal tubular acidosis problems with kidney acid handling occurs in quite a lot, maybe half of patients. Possibly due to copper buildup or autoimmune links.
Interesting.
Hypothyroidism is also common, develops in about 20%.
Okay.
A major concern is hepatocellular carcinoma, HCC, liver cancer. The risk is mainly in those who develop cirrhosis, especially men, and those who don't respond well to UDCA.
So screening is needed.
Yes, generally recommended for those with advanced disease, particularly men, usually with abdominal ultrasound and checking AFP blood levels periodically.
Right, important point.
Then there's the malabsorption issue. We mentioned problems absorbing fast leading to fat-soluble vitamin deficiencies. ADEK needs monitoring and supplementation.
And the prognostic scores help track risk.
Yes, the Mayo score and newer ones that incorporate UDCA response help stratify risk for complications and guide management intensity.
Okay, so kidney, thyroid, HCC risk in some, and malabsorption, key complications. Well, that really has been a deep dive into primary biliary cholangitis. Thank you. So just to quickly recap the absolute essentials, it's that autoimmune attack on the small bile ducts. AMA positivity is the key diagnostic clue, and early diagnosis followed by UDCA treatment is crucial for improving the outlook.
That sums it up nicely.
Hopefully, this breakdown has made PBC a bit clearer and more memorable for your revision. Remember, keep digging, keep learning. And for more fantastic resources to help you prepare, definitely check out passmsra.com and also freemsra.com.
Great resources.
Absolutely. Well, best of luck with all your studies.